Welcome to CE on ReachMD. This activity titled, Optimizing Iron Deficiency Management in CKD, IV Iron Replacement Therapy amid the latest KDIGO guidelines, is provided by Medtelligence. Prior to beginning the activity, please be sure to review the faculty and commercial support disclosure statements, as well as the learning objectives.
This is a continuing education on ReachMD. I am Dr. Julio Núñez, heart failure and cardiorenal specialist. With me today is my friend and colleague, Dr. Patrick Rossignol. Hello, Patrick.
Hello, Julio.
In the next minutes, we will discuss about iron deficiency assessment and treatment in patients with CKD. Very interesting topic. Let me start with a clinical case. This is a 78 years old man with a history of hypertension, type 2 diabetes, and the patient presents stable chronic kidney disease classified as CKD G3B A2. The patient is receiving a stable GDMT, including statin therapy, ACE inhibitor, thiazide-like diuretic therapy, dapagliflozin 10 milligrams daily, semaglutide up to 1 milligrams weekly, and also finerenone on 20 milligrams daily. On the visit, the evaluation was blood pressure 132/82 milligrams mercury. Electrocardiogram shows sinus rhythm 70 beats per minute. Non-anemia, normal glycated hemoglobin 6.5%, normal no dyskalemia, and GFR, stable GFR about 38, and UACR about 32 milligrams grade. Patrick, I have a question for you. Do you miss iron deficiency evaluation in this patient?
Yes, indeed. According to the latest KDIGO guidelines, a proper evaluation should include a complete blood count, reticulocytes, ferritin, and transferrin saturation, TSAT. Such screening should be performed at referral and regularly during the follow-up and when symptoms suggest anemia. Minimum testing frequency increases with CKD progression in other CKD severity, annually in CKD grade 3, twice yearly in grade 4, and every 3 months in grade 5 or dialysis. And why should we proceed? So there are indeed many observational studies which showed an association between iron deficiency and adverse outcomes, overall mortality, adverse cardiovascular outcomes, but also impaired quality of life. And in several of these studies, the association of iron deficiency with adverse outcomes was found independent of the presence of anemia. And finally, I should mention that the strongest evidence supporting a causal effect of iron deficiency on outcomes stems from the pivotal trial we will talk later on, but which showed that the iron used proactively compared to a more conservative approach led to better cardiovascular outcomes. And this data provides the rationale for diagnosis and treating iron deficiency in people with CKD.
Thanks, Patrick, for your clear response. You convinced me. Here we have the hemoglobin and also iron deficiency assessment in this patient. The patient had a ferritin levels of 80 picograms liter, and also TSAT, transferrin saturation index, was 18. And also remember that the patient has no anemia, hemoglobin 13.5 grams deciliter.
Julio, can you tell us a little more about this? What about the differences and potential causes?
First, this patient displayed non-anemic iron deficiency, specifically, and according to KDIGO guidelines, the patient has systemic iron deficiency characterized by low ferritin, low TSAT. In CKD, we may also classify patient as iron-restricted erythropoiesis when patient has low TSAT, but also higher values of ferritin in values above 100 nanograms milliliter. So we need to distinguish this type of both classifications. In heart failure, we have the similar but with different names. But regardless the type of iron deficiency, when we look for a recent registry in order to know what the prevalence of iron deficiency KD patients is, we uniformly see that in most of registries, most of patients, up to 50 to 70% of patients with CKD exhibit some degree of iron deficiency. But most importantly, in most of cases, Patrick, iron deficiency is not assessed, is not measured. The main problem is that in many cases, physicians are not recognizing iron deficiency because it is not measured. And what are the potential causes of iron deficiency CKD patients? Multifactorial, bleeding, most of them gastrointestinal, also urogenital, chronic inflammation may also play a crucial role. Remember also iatrogenic, use of drugs like anticoagulants, multiple blood testing, patient on hemodialysis, and also increased iron consumption due to erythropoiesis stimulant agents, use of these drugs. So you also state that iron deficiency is associated with increased risk of adverse events beyond the presence of anemia. This is true in heart failure, and this is true in CKD, but not also increased risk of major adverse events, but also importantly decreased quality of life, more fatigue, worse concentration, lower well-being, more anxiety, more depressive symptoms, and also worse neurocognitive results, especially decreased memory status, mental speed, and attention. For those just tuning in, you are listening to CME on ReachMD. I am Dr. Julio Núñez, heart failure and cardiorenal specialist, and here with me is Dr. Patrick Rossignol. We are discussing the role of IV iron replacement therapy in iron deficiency patients with CKD. We have pointed out the importance and the prevalence and the clinical associated effects of iron deficiency CKD patients. But what recent KDIGO guidelines say about iron deficiency treatment in CKD patients?
Thanks, Julio. As a matter of fact, there are two major statements in the latest KDIGO guidelines. One statement concerns patients on dialysis. It is now recommended to implement a proactive iron management strategy. In other words, initiating iron therapy is suggested if ferritin is below or equal to 500 nanograms per milliliter, on TSAT below or equal to 30%. On a proactive approach, in other words, regular maintenance doses is preferred over a reactive approach to ensure stable iron status and potentially improved cardiovascular outcomes. And as I stated earlier, this statement essentially stems from the pivotal trial results, which randomized more than 2,100 participants with CKD stage 5 on dialysis to receive either high-dose iron sucrose administered intravenously in a proactive fashion compared to a more conservative, less reactive fashion with a lower target from SAT on ferritin. And importantly, the rate of the composite outcome of fatal or non-fatal myocardial infarction, fatal or non-fatal stroke, or hospitalization for heart failure after a median of 2.1 years was significantly lower in the group receiving proactive versus reactive treatment with a hazard ratio of 20%. What about patients not on dialysis? For patients not receiving dialysis or those receiving peritoneal dialysis, initiation of iron is suggested at less stringent ferritin TSAT thresholds, reflecting different iron losses and inflammation burdens with a ferritin below 100 nanograms per ml on TSAT below 40%, or ferritin between 100 and 300 milligrams per ml on TSAT below 25%. And regarding the preferred route of administration, IV iron is preferred in hemodialysis patients because of its efficiency on reduced pill burden with the proactive approach I depicted. And for those patients not receiving hemodialysis, of course, either oral or IV iron is suggested, but this is based on the individual patient's values, preferences, tolerability, and costs. acknowledging the fact that IV iron may lead to a faster correction of anemia with fewer side effects. In any cases, if oral iron has an inefficient effect after 1 to 3 months or is poorly tolerated, patients should be switched to IV iron.
Excellent summary, Patrick. It is absolutely evident that KDIGO guidelines recommend to move for a more proactive, not just assessment, but also treatment of iron deficiency in CKD.
Julio, as a cardiologist, what guidance can you give nephrologists regarding the use of the IV iron therapies?
So in heart failure, we have a lot of experience and trials assessing the effect of iron deficiency treatment in patients with chronic but also in acute heart failure. As a summary of the evidence endorsing the use of iron treatment in iron deficiency patients, first, iron deficiency is highly prevalent in heart failure, similar as we see in CKD. In several registries, iron deficiency is about 50 to even 80% in acute heart failure settings. So iron deficiency is highly prevalent, similarly as occurs in CKD. Second point, oral iron treatment seems not the best choice in heart failure patients. There is one randomized clinical trial that evaluates the use of oral iron treatment in patients with iron deficiency, heart failure patients. And at 16 weeks, we were not able to find any differences in terms of functional capacity assessed by PICView-2, no difference also in 6-minute walk test, and no differences in another endpoint. So with the evidence we have right now, we cannot suggest in heart failure patients a regular, proactive treatment with oral iron. Third, the clinical benefit in heart failure patients is independent of the presence of anemia. So I think it's very crucial point. We just need to separate what anemia and what iron deficiency is. And in heart failure patients, the benefit is similar. Most patient benefit regardless of the presence of anemia. And finally, I would like to say that looking at the most important trials in heart failure, iron supplementation appears to have the greatest benefits in those patients with lower values of TSAT. In this setting, there is some others that suggest that we should simplify the iron deficiency definition and treatment just based on TSAT. In heart failure, there is some others suggesting we need to simplify and treat patients just based on TSAT lower than 20%.
Thank you very much, Julio. These were great points, and you no doubt convinced me as a nephrologist.
Thank you, Patrick. Before to close this session, we want to give to the audience some take-home messages. Let us start with Dr. Rossignol.
Thanks, Julio. I will call our colleagues to action, highlighting the importance of screening, anemia, iron deficiency on the one hand, but also the role of IV iron replacement therapy in iron deficient CKD patients, both on dialysis and in non-dialysis dependent CKD patients.
Thanks, Patrick. I just want to repeat the similar message than provided by Patrick. I would like all colleagues that assess patients with CKD, but you need to proactively assess and treat iron deficiency in CKD patients, and just treat and assess and treat these patients beyond the presence of anemia. Thanks for being here. And that's all the time we have today. So we thank our audience for joining us. And thank you, Patrick, for joining this interesting session.
It was a pleasure, Julio. Goodbye.
Goodbye.
You've been listening to CE on ReachMD. This activity is provided by Medtelligence. To receive your free CE credit or to download this activity, go to reachmd.com/CME. Thank you for listening.